Welcome back to Pompano Beach Fire Rescue. I'm Captain Perrin. In today's segment, we're going to be going over the Pompano Beach Fire Rescue 2019 EMS protocols.
Good afternoon, guys. Frank Algano, Assistant Chief of EMS, ready to do protocol training today. So let me give you a little overview of why we're doing the protocols and why we're changing other protocols and why you're all here today. Instead of our common protocol rollout, this is more significant. This is a big game changer for us. As we're going through our protocols today, I really want you to pay attention to the 4 chapters in the beginning are more significant of the changes of the 12 chapters that are in this protocol book. So we have the first 4 chapters are game changers. They represent mostly of the dramatic changes here. A lot of minor revisions as well, but there's some game changers that Chief Matt Whitten is going to be talking about today. He's going to be running the protocol rollout today in its entirety. I'm simply here to do the introductions about this and why we're here. As we go forward, who's downloaded the app so far? Okay, most of you guys have downloaded the app. It's interactive, it's hyperlinked already. You'll notice that when you're going through the app on your phone, that when you're looking at the bottom of the green marker here, as you're going forward, you can get back to your back page here. It's all hyperlinked. You look at certain medications and certain procedures. It's simply easy for you to get back and forth on your iPhone or Android device. They're all hyperlinked on both devices. So getting back to the beginning here. Okay, why are we here? Why are we doing these protocols? What's the difference between this protocol as a game changer versus what we've been doing all along? Well, as I committed to you guys, we were going to do something that was easy and accessible for you to get on your phone, on your laptop's computer. Right now, your current protocols are really tough to find on the S drive, and out in the field, if you're not connected wirelessly, you're really not going to find those. They should be accessible. You know, there's over 600 pages of the Government protocol out there that we're using. This format here is 154 pages with pictures and hyperlinks, so it's easy for you to swim through, and it includes the adult and the pediatric protocol information on the same page. So it's a concise protocol. It's what you've been wanting for a long time. I mentioned to you guys this is what we're going to be doing. So here's your product arrival. We're filming this for the other classes to see, so we have all consistency of delivery of what we're doing today. So what we're concerned about is protecting the citizens and their health, and our practitioners giving EMS care for our citizens that's progressive, good science, and well-researched. That's what these protocols represent. There's a lot of different movements out there right now in Broward County. There's a lot of different departments doing different protocol things, and it could be very easy to get trapped into looking at somebody else's doing work out there that's not really evidence-based science based on American Heart Principles or other well-researched abstracts out there. So what we're focusing on is all the science that you see here is based on the American Heart Association guidelines, well-researched and published studies that are not theoretical. They're actually based in science and have been replicated for the same outcomes and conclusions. So all the things that you see here are defensible in court and with what you and your patient care, okay? So that's why we're doing these protocols. That's why it's a game changer. We partner with Broward Sheriff's Office because they've done a great job on their app, and their medical director, Dr. Jim Roach, I give a lot of credit to for authoring a majority of these protocols. We have Dr. Farrell, myself, BC Whitten, and Freddie Sampson come along with other protocol committee members developing this protocol for you so that it's easy to be accessible on any device that you have. It's electronic 24/7 in case you're in that 2 o'clock in the morning call and you're trying to find out, oh, I got to get this right step. I want to make sure I include this medicine or this procedure. What was that? Okay, so you can look at it real quick. All these numbers, the Florida Poison Control numbers in here is hyperlinked. Everything is wonderful. There's a lot of reference material that BSO has put into their app, and we're simply sharing their space. So they've got the app. They're more than congenial to let us come into their app world and let us put our protocol into there. So when you're seeing our protocols, ours really mirror images their protocols quite a bit. Their protocols that are differences, probably 95% is the same, but the protocol difference would be the blood products, transfusion protocols. The airway protocols would be RSI and etomidate. We're not adopting those yet. We need more training behind advanced airway classes, and then we can go to RSI and use etomidate. We're probably 1 drug right now away from our inventory in our drug box of using etomidate. So we're not there yet. We got to do some more training. We don't have a lot of advanced area cases that would require that, so we're not so hasty about having to do that right away. We're not doing vaccinations. We're not giving antibiotics or inoculations out there in the field. That seems to be a community paramedic movement that's happening out there. We don't need to do that in our community. We have 5-minute transports in a lot of cases, and our patients wouldn't require that kind of practice anyway as an EMS practitioner. So, and going back here, I'm going to go back to a couple of slides. Let me get the general information here. Go back. Okay, whoops. Go back
Click
to the
the
beginning.
second button down on your remote.
Okay, so our medical directors that helped write this, obviously, is Dr. Michael Farrell, and also Dr. Roach and Dr. Paley had a lot of input on creating these protocols today that you see. So we got the team of really sharp people with, again, with BC Whitten and Freddie Sampson helping in the trauma part of the protocols. And we got to give that credit to BSO for really helping out quite a bit and giving us this product to work in and swim into. Any questions for this before we get on to the next page? So let's continue on with our protocol training today. We're shooting this thing so you can access this on Target Solutions. You already know how to use the app, going back and forth. BC Whitten will get here and he'll talk to you about what the red highlights of the protocols mean. And we're ready to go. Any other questions? Anything else? Nothing? Good? All right. Thanks, guys.
Okay, so let's get started. So the first section's the general information. So throughout the protocol, you'll reference back to this periodically. So this is more general. When I go over each slide, I'm going to just cover what I feel like is a change or important topic. I'll pause slightly before I forward, so if there's any questions, please ask, because no two classes is the same, so it often depends what kind of questions we have. So that's why we're here. So please ask questions if you have any. So this slide, this is an important slide. I don't know if you heard people talking about it. The intent of this slide, there is no way you could create a protocol to cover every scenario. So this is not meant to be strictly followed. We want to be able to have the medic to be able to think and change the treatment plan if the scenario you're faced with doesn't exactly fit one of the protocols. When we go through, we'll actually talk about some examples where it might be a good idea to use this. So basically what it's saying is 2 medics, if they agree, have the authority to deviate from the protocol. So obviously the intent of this is not to say, I don't have a protocol, I can do whatever I want. This would be the exception to the rule. But if you in good faith decided, I feel like this is better for the patient, this gives you the authority and the coverage to be able to do that. Understand? Perfect. Okay, so medical administration. The one that sticks out to me the most is the IO. So you notice now we talk about the order of preference, the humerus is number 1. So we're very comfortable using the tibia for the IO, but now we know, particularly if someone's a diabetic or has some vascular disease, very high chance for infection. We know we've had a couple cases in Pompano where the person had a bone infection, we think because of the IO, and it put them in hospital for a little bit. Not to say you couldn't do it. A lot of the stuff we do is a risk benefit, but we know now, because the blood supply is much better at the humerus, very little chance of infection. So that's why, one of the reasons why we're going to be going to the humerus. So we don't have enough time to do that training, so we know we're not going to cover everything. We're going to have to do some more intense training on certain topics. That's one of them. So there's discussion where exactly you would go on the humerus. We're going to straighten all that out and do some specific training on that. You notice the pediatric, we're still using the tibia, but these are basically written in the order of preference. So you can still use all those sites if you feel like it's appropriate. For the needles, we're trying to make it simple. So we'll get on the same page of logistics, so we should just have basically 2 needles to choose from. A 23 gauge for the infants and small children, 21 gauge for larger children and adults. So it should help that. You notice we still have the MAD device, so you can still give the drugs intranasally, but you'll see it's probably rare that we would actually use that route now. Okay, this is a big page for us. So throughout the protocol, you're going to hear us talking about push dose epi. And we use the term so much, it's real important you understand exactly what push dose epi is. So if I was to just grab the box of epi we're used to, what concentration is this? 1 to 10,000, exactly. We're looking to get to 1 in 100,000. So there's a couple different ways you could accomplish that. One would be you could push 9 mLs of epinephrine out, draw back up 9, you would have your 1 to 1,000. That wastes the epi, but you could do it. What we feel like the better way to do is how many mLs are in my saline syringe? 10. So I would push out 1 mL of saline. You could use the 3-way stopcock, hook both syringes up, and what I'm doing is I'm pushing 1 mL of epi into my saline. So now I have 10 cc's in my syringe, 9 cc's of saline, 1 cc of epinephrine. This is my epi 1 to 100,000. So when we talk about it through the protocol, this is what we're talking about. So I don't care the age of the patient, I don't care the weight of the patient, it's the same administration. The reason we separate it between adult and pediatric is because of the endpoints where you would stop administering it. And that's the blood pressure. That's the only reason. Everything else is the same. You push 1 mL every 30 seconds until you get your endpoint. So for the adult, it would be a systolic of 100. For the pediatric, we'll talk about that in a second. All right, is that clear about what epi 100,000 is? Okay. So you see there are additional medications listed. These are ones that need to be diluted. If you look at your medication sheet, I believe it's on page 149. We have one of the medication sheets. 147. If you notice, some of the medications are in red. That means they need to be diluted. So on your medication sheet, thank you. So on your medication sheet, if the medication is in red, that means they need to be diluted. You'll notice in the protocol, some areas are red. That just means that needs special attention. Maybe there's a little emphasis that needs to be put on it. It's something different, something new. But on the medication sheet, red means it needs to be diluted. So these 3 is for pediatrics. Ketamine, you would dilute for the adults, and we'll go over that as we go through. With the drugs, we're differentiating the term infusion and drip. Now, in reality, those terms are interchangeable, but I'm using those just so you understand there's a difference. An infusion is something that you administer over a definitive amount of time. So for the adult, it's going to be 10 minutes for both. For one pediatric infusion, 25 minutes, but everything else for the whole protocol would be over 10 minutes. So if I was to use the drug, so if I was giving amiodarone, once I put the drug into the 50 ml bag, now my issue is how do I get that 50 ml bag into my patient in 10 minutes? And it's the same every time. I'm going to use a 10-drop set, 1 drop a second, and that will give the whole bag in over to 10 minutes. So I really, once I get the drug into the bag, I'm not concerned with the drug. In reality, I'm concerned now with the drip rate. So that's an infusion. Then you have what we would term a drip, meaning in theory that could be run forever. So dopamine would be an example, Levophed. We got rid of all the drips. So now, wherever you, in the old protocols, you would say, I would use dopamine or Levophed, we're now going to use the push dose epi. And again, the dose never changes. I don't care age, weight, it's always 1 ml every 30 seconds until you get that desired blood pressure. Okay? So this screen, the incapacitated person law, why do we put this on all of our protocols? Why is it important?
Someone has the right to refuse care.
Right, so we always talk about these gray areas. Well, the person had, I'm pretty sure he had been drinking, he had a medical emergency, his vital signs were altered, and there's always a gray area of, well, can I take him, can I not take him? A good way to think of this protects us from even the thought of, well, we can't take this person. If you in good faith believe they're having a medical issue, they're intoxicated, this gives us the right, the legal authority to take them to the hospital. So that takes away, hopefully takes away any concern of saying we're kidnapping someone, but in reality, when we're there unseen and someone says, I'm absolutely not going, now it comes down to, do I forcefully put them on a stretcher? We're not saying we're going to start putting our hands and putting people forcefully on the stretcher. So down below, we would never advocate someone using unreasonable force. So if you were faced in those scenarios, you want to, at the end of the day, be able to say through your actions and your written report that you made every reasonable attempt to get that person to go. So that might include getting family members involved, calling BSO to the scene. So when that final decision happens, if BSO says, look, we're not willing to take the person forcefully, you may decide we're not taking the person. But make sure you're documenting that it's very clear that you made every reasonable attempt to transport the person. All right, is that clear? So patient assessment we left on there. Most of us know how to do a good report. This is really there to give you an idea of what a thorough report would be. A lot of the language we chose was very intentional. So you'll notice on a lot of the pages, we didn't put shall or must. We use words like should or could or consider. So depending on the report, the patient, this would be examples of what would make a good report. So when we look at a report during the QA process, what we're basically asking is an idea of what you walked into, what you were observing, what the patient told you, the assessment, your plan, basically what you did, and the one area that I feel like we could improve in is how we left the patient. So if you had an overdose and you gave Narcan, you did perfect treatment, and you documented, and we transported the patient to Imperial Point, and then the report ends. Well, we need to know, well, how was the patient in the end? So it doesn't have to be real elaborate. It could be something as easy as, upon transfer, report was given to RN Nick, patient alert-oriented ×3. That paints a very clear picture. So doesn't mean it's elaborate, but try to paint that picture so there's no question that we provided great care. This page, again, some general information, but a couple areas that are worth mentioning for an unresponsive adult. We're bagging the patient. It talks about if after 2 minutes you're still bagging and need to support that airway, you're going to advance using a more advanced airway, so either an iGel or an ET tube. So does that have to be a very literal meaning of that? And what I mean by that is, say you had that same overdose patient and you gave Narcan and you notice, oh, we're past 2 minutes bagging this person. Is the intent of this protocol that, yep, we have to intubate him? No, that's not the intent of this. Because in that case, you reasonably foresee that that patient's going to come around. So that's not the intent of this protocol. This is designed for the patient you're bagging, and after 2 minutes, there's no reasonable, foreseeable reason why the patient's going to start breathing again. That's the patient we would really want to consider upgrading the airway. If you do, you can use an ET tube or an iGel. We're no longer saying you have to use one or the other, except if it's a cardiac arrest. In that case, we're going to go with iGel first, and the main reason of that is no one can intubate faster than you can place an iGel. So we'll get it going with that, and you'll see, depending on which of the algorithm sides we go down, you may not even ventilate the patient, but we'll go over that later. So that would be the only exception. If you decide you want to intubate and you have 2 failed attempts, then we're asking you to use the iGel. All right, any questions on this one? The pediatric. What is the preferred method of ventilating? The bag mask. So we put that in there because we don't want you to feel like you have to intubate them, you have to use the iGel. So particularly for the pediatric, if you're ventilating well, so you have a SAT above 95, 99, do you have to intubate that patient? No. But what if you know the hospital's going to intubate them when you get there? Shouldn't we intubate them? Don't confuse pre-hospital with the hospital. Even if you in your mind know that patient's going to get intubated at the hospital, our job is to get a viable patient to the ER. So if I'm bagging perfectly well, don't stop what you're doing to try to establish an ET tube because you think that looks more advanced. So we're not going to do things for our ego. We're going to do things because they make sense for the patient. So if you're bagging effectively, leave it alone. I always try to tell people, before you do something, ask yourself, what am I trying to fix? If the answer is nothing, then maybe you don't need to do it, and that's okay. And then it talks about if you have to use the advanced airway, then again, the iGel or ET tube. Okay, this talks about oxygenation. So we've for a while now talked about you don't have to give oxygen. Oxygen may be bad even if the person has a normal pulse ox. So say we show up and John's having chest pain and he's got a SAT of 99 and I put oxygen on him. Well, we now know oxygen is actually a vasoconstrictor. So if he's having an MI, me putting oxygen might have actually made his MI worse. So we don't want to give oxygen unless they need it. Now with that being said, if you think he's having trouble breathing, he's telling you he's having trouble breathing, we're going to give oxygen to the patient. So don't overthink this one too much. There are 2 cases that you would definitely give oxygen no matter the pulse ox, and that's the traumatic brain injury and someone 3rd trimester pregnancy. Worst thing we could do for those 2 in particular is withhold oxygen, so we're going to give oxygen no matter what in those. So that would be our 2 exceptions. The ventilation rates, make sure you're realizing when you're reading it, one of them says with a pulse and one of them says without. So with a pulse, we're all used to rescue breathing, 1 breath every 5 to 6 seconds. We made it a little simpler, just using 1 every 6 seconds. But without a pulse, now we're ventilating 1 breath every 10 seconds. So that is a change. So just make sure you're realizing 1 rate is with a pulse, 1 rate is without. Okay, this section, it talks more of, if you notice the language of should, these are patients where you should be considering using the capnography. Suggestions where you should be considering using the ECG. And when we get to the vital signs, we talk about things you should do, and one example would be the temperature. So if you think it's appropriate, so you're trying to rule out a sepsis patient, fever, that's why the language says temperature as appropriate. And then with the blood pressure, how many people take a manual blood pressure on every patient, the first blood pressure? Right? The monitors now are very sophisticated, they're very accurate, so we wrote it to what we actually do. So you can take a blood pressure with the automatic cuff, but if you suspect there might be a problem or it's very abnormal, then we're asking we confirm it with a manual blood pressure. Right?